Welcome to our discussion today on the treatment of Alzheimer's disease. Good to have you. Thanks for visiting, and I hope this helps you. I'm going to spend most of my time speaking today about the new drugs we're working on here at the Research Center, but I'm also going to tell you the background of what we have to use to treat patients today. I'm Dr. Jim McKinney. I've spent 30 years at MCV, VCU, on the schools of medicine and pharmacy faculties, teaching, and 22 years ago I brought my research out of the university and formed National Clinical Research. So today I'm Professor Emeritus of VCU and President CEO of National Clinical Research. Now, as we think about this disease, I want to take you back to the beginning. This is Auguste Deter, the first patient we know had Alzheimer's disease, and she exhibited many of the characteristics that we now attribute to Alzheimer's disease. Dr. Alzheimer's, her physician, didn't really know how to treat her. He'd never seen such a case, neither did his colleagues, and so it was a learning experience. And frankly, a lot of what he showed us way back then is still something that we're working with today. You'll see about that in just a moment. My point here is to say this. If Auguste Deter were alive today, and we could take her to the best neurologist, the best of the best, if we could go to the most outstanding institutions, the Mayo Clinics, the Johns Hopkins, Cleveland Clinics, the Duke Universities, many and sorted, wherever we took her, the sad story is that none of them would have a treatment to give her, even though it's 101 years later. None of them would have a treatment to give her that would slow or stop or cure this disease. We are in desperate need for an effective treatment. Now, it turns out I think we have one on the horizon. I want to tell you about it today. So it's exciting news, I hope. We'll see. But let's start here. What can you do today on your own? Non-drug treatment. And it turns out just healthy living, the kinds of things we've been taught most of my life in the last 40, 50 years to prevent heart disease, turns out it's also good for our brain health. Exercising on a regular basis, aerobic exercise and strength, whether it's walking, whether it's working on machines, whether it's working on your own, Pilates, all of these things have a place and fit into a system as long as there's a routine, regular course of exercise, and it involves both strength as well as aerobic. Cardiovascular risk factors turn out to be also brain risk factors. The better we control our diabetes, if we have it, or our blood pressure, cholesterol, our weight, and not smoke. All of those things help us with this disease. By the way, it helps us in this way. The disease is going to come on anyway, but it's going to come on probably later. It's going to be a lower level at first, and it's going to progress a lot less rapidly. So these are important things that are to do before the disease is experienced and as well as after. Use your brain in as many ways as you can. The more you use it, the more you expand its capability, almost like exercising your heart increases collateral circulation. Using your brain in many different ways increases its capacity as well. So I would challenge you to think about new things you could do, not just reading, it's important. Brain exercise is important. Social interactions, talking to people, interacting, thinking, but listening to some music, learning a new skill, ways that you haven't, things that you haven't done before that requires your brain only expands and gives you more capacity, I think, and to slow down any kind of disease that may be behind. And very finally, get some good sleep. Very interestingly, I think I told you in the first lecture, if you listen to it, on causes, that a protein called amyloid beta may be the culprit that causes the plaques that leads to the disease. That protein actually gets flushed out of your brain during the night as you sleep, so that any unused protein, or much of it, is pushed out of the brain. So having a good night's sleep that's not interrupted every 2 or 3 hours by waking up and going to sleep and waking up and going to sleep, a good night's sleep. And that also means if you have sleep apnea, having that taken care of so you can get a good night's sleep is important. So here are the medications currently available to doctors for patients who have Alzheimer's disease or even early, very early, mild cognitive impairment. These are the medicines we look to: Aricept or donepezil, Exelon, and galantamine. These are drugs that all help the brain cells signaling or communicating one to the other, which is a very important task if we're going to remember things and recall things and think and learn and so forth. These are the process of brain cell communication is key. You see to the right upper there, you see a picture of what's called a synapse. That's the junction between a tubule from one brain cell, the end of it, to the beginning of the tubule for another brain cell. That's how it's communicated. The messaging, the signaling from one brain cell goes to another one. So these drugs enhance that transfer from one brain cell to another, that signaling. Memantine is also involved with about the same thing. It keeps this signaling from becoming excessive, preserves sort of a normal functioning within that synapse. So, but what you see here are treatments that are beneficial if your brain cells are functional and can still communicate. But as you may have learned, if you listen to the Causes of Alzheimer's lecture, the brain cells become dysfunctional. They begin to degenerate, and they become to the point where they're not any longer functional. They're breaking apart. At that point in time, all along that point in time, these drugs have no effect. These drugs do not slow or stop or cure the disease. The disease goes right on in spite of their presence. So doctors really don't have anything that's much more than symptomatic treatment currently to prescribe for this horrible disease. So let me tell you where we're going and what's happening in the Research Center for Alzheimer's disease. First, there are medications that are aimed at removing the amyloid plaque that builds up. We think it's the first mechanism, the first step in the formation of Alzheimer's disease, certainly the formation of plaques. Plaques are neurotoxic. They adversely affect the brain cell. So if we can get rid of those plaques, we think that may be helpful. I'm going to show you some evidence today of that. So we're looking at medications that actually remove the plaque, and we're looking at medications that block the production of this plaque or this protein. So if you don't have the protein, you can't form plaque. If you have a plaque already formed, then can we get rid of it? The second group of medications, which is actually much more in its formative stages, is to stabilize the tau proteins or the tau proteins. These proteins form a skeleton around the major tubule through which the brain cell communicates, the axon. And as the cell degenerates from the formation of plaque, these proteins begin to strip off and tangle together. That's where Dr. Alzheimer saw tangles. It may have been these tau proteins. And the cell then deteriorates and sort of blows up, if you would, and it's not functional and eventually dies. There are medications that are being developed that are trying to stabilize the tau protein in its place and keeping it from unraveling. We're going to concentrate for the next few minutes on the medications we're studying to remove the plaque in the first place. And here's a list of them. I'm sure these are all hard to pronounce. Let me just go down with you. Solanezumab, aducanumab, gantenerumab, crenezumab, and then a therapy that doesn't yet have a name. Notice that each one of those ends with the letters MAB. MAB stands for monoclonal antibody. You see it at the bottom of the slide, monoclonal antibody. So what is happening here is that the scientists are trying to mimic our immune system. Our immune system makes protein antibodies to ward off injury, to fight off infectious processes, to help healing. Whatever our body needs, our immune system is there to try to help, and it does so principally by making antibodies. Well, man can make antibodies also. It's learned how to do so, and And even more so, man can make a human antibody made up of human amino acids and formations that are in every respect human, so that when we give it to a patient, it's not rejected. An allergic reaction is not produced because the body sees it as something that's normally and naturally a part of the body. Let me show you even further what I'm talking about. So we go off in the lab and we make this antibody that recognizes only amyloid protein, so that when we give it to a patient, that antibody goes to the brain where the amyloid protein is, attaches to that protein. And when that happens, the body sees this complex, this combination, as trash or as garbage. And so it pulls it inside the cell. And inside the cell, there's a formation called the lysosome, which is there to sort of break down that product as if it were a garbage can or garbage disposal. And when it does that, the protein, the antibody, all go away. They're reduced to their atom elements, the carbon, the hydrogen, the oxygen, and so forth. So the beauty of this is we form an antibody that goes to the brain, grabs the plaque, pulls it away, and then is destroyed within the cell. Never has to go through the kidney for elimination, never has to be broken down by the liver, it never has a chance to interact with any of the medicines we're taking. So it has that great advantage. Let me tell you about one antibody in particular. This is aducanumab, and this particular study that I want to present to you is a phase 1. That means the first time it was ever given to a patient who had the disease. You see the inclusion criteria is that the person had to have memory loss, evidence of memory loss, and it had to have a positive PET scan, which means they had evidence in their brain of having amyloid plaque. Those are the two things that they had to have. Patients received either placebo or the medicine aducanumab in 3 different doses, 3 milligrams, 6 milligrams, and 10 milligrams, and they received that for an entire year. Let me show you the results. First, let me tell you that this particular medication, this antibody, monoclonal antibody, is a very large molecule, and it can't be crushed up and put into a pill, so we have to give it as an injection. Some of them are given subcutaneously in your tummy or your thigh or your arm. Others have to be infused in a vein in your arm, as is being shown here. Many of the ones that we're working with have to be infused, and the infusion is done once a month. So here's the result of this particular study. It was a short 1-year study with 120 or so people. So this is a short study, a small number of people, simply to see, try to answer the question, does it look like the medicine is going to work? Along the left side there you see 4 different brain scans. All of these are PET scans for amyloid plaque at baseline. And in each one of them you can see yellow and you can see red. Red is more heavily concentrated plaque. Yellow is less concentrated plaque. But in all cases, in all 4 patients, down the line at baseline, you would say they have Alzheimer's disease because, one, they have memory loss, and now they also are found to have a positive PET scan. All these patients, by the way, had an average of 20% memory loss. So the placebo was given to the patient for a year, and you see comparing the left image, PET image, to the right PET image after 1 year, I think you can conclude there was no difference. And in fact, there was barely a worsening. But when the medicine was given at 3 milligrams, 6 milligrams, and 10 milligrams, if you look at the images on the right compared to the images on the left, down the various rows, I think you can say there's less plaque there. There's less plaque in all cases. As a matter of fact, there's 40% less with 3 milligrams, 62% less with 6 milligrams, and a whopping 80% less. This is remarkable. I said before in the other lecture, if you listen to it, that it takes 2 or 3 or maybe even more decades for the plaque to build up. And here in 1 year's time, the highest dose is able to remove 80% of that plaque. So the question, can this medicine remove plaque? And the answer is yes. It shows it right there. But the next question is, does it help memory? And I'm going to answer that by looking at the very top and the very bottom groups. Now, if you remember, I said all patients who started the study, on average, had a 20% memory loss. So what happened when we gave them placebo? What happened at the end of 1 year? Their memory worsened. It went from 20% to 32%. So a pretty sizable increase in memory loss in that patient. Looking at the group at the bottom here, you see it went from 20% to 21.9%, a little bit less than 2% worsening. And there's a lot less plaque there. So can the drug improve memory? You bet it. Can it stop the advancement, aggressive advancement? It did. Can it stop the disease? It didn't, because the disease progressed 1.9% over 1 year. But our thinking now is that we continue treating the patient with this medicine for another 6 months or for another 12 months. Perhaps we can get rid of all the plaque, and maybe then we can stop the disease. But that's the question we're now asking in all the large studies that we're conducting. As for side effects, there actually are very few, and we understand them now enough to know that we think that it's a very safe and very practical medicine to use in masses of people to treat this disease. The main issue that we're concerned about this is a symptom that's called RE. It stands for amyloid-related imaging abnormality-edema. If we did an MRI of this patient, who received this medicine, within the first 3 to 6 months, we may find what we called microscopic evidence of water or edema or swelling. Those terms can be used interchangeably, but microscopic forms of that in the brain on an MRI scan. And you see the percentages of patients affected. It's not supposed to be there. That's not supposed to happen. And of course, we don't want to do anything that's going to injure the person and cause more damage than good. What we found, though, as we have treated now so many people with these kinds of medicines, we know that if we continue the treatment, this problem just goes away and it doesn't recur. And so we watch patients very carefully for this occurrence. If they happen to have symptoms, and especially if they happen to have headaches along with the findings, then we would be more cautious in continuing treatments. We may recommend to them that they stop the treatment and allow for the edema to go away, and then to restart it at a lower dose later on. But we are aware of this problem. Again, we haven't seen any permanent damage caused by the medicines. We think this is a transient finding that's probably associated with removing that plaque in the first place. The final thing that we'd be concerned about is having allergic reactions, and you can see they almost just don't even occur. The drug is accepted by the patient's body very well. Now, I just want you to see what happens in most of our studies for all the medicines we talked about. Patients are admitted to the study who demonstrate some memory loss and who have a positive PET scan. You see the age ranges that typically are included. Patients are given either one dose of the medication or 2 different doses or placebo. Now, during the time of the study, which in the cases of our studies, these studies run 18 months to 24 months. During that time, we don't know what the patient's receiving, whether it's real medicine or not. But after the study is concluded, then the real medicine is given to all patients until the medicine is on the market. And that's a huge advantage, so that everybody is assured of getting real medicine sometime during the study, and perhaps for the entire study. Well, that concludes our summary. I hope you're as excited as we are about what's happening here. I did reference several times another lecture, that one on the causes of Alzheimer's disease. So if you want to go listen to that, it's probably on the homepage of the Alzheimer's Research Center. We also have a wonderful NOVA program. If you'd like to listen to that, it lasts a whole hour, but it's wonderfully presented and gives you a good background of where we are. Thank you.